Pleasure to introduce Dr. Amir Marvasti here from Southern California to present to us SLT and the management of glaucoma. Thank you so much for joining us today. Up to you.
Thank you, Jennifer, for the introduction. Can you just give me a thumbs up that you can see the screen well at this point? All right, very good. So thank you everyone for participating. Thank you LIGHTMED and Advancing Eye Care for organizing this. I understand we have a really good participation, so I appreciate everyone spending their time here. Certainly miss in-person events, shaking hands, but at least this is some way to still be in touch. So I'm an ophthalmologist in Southern California, as Jen just said. The practice I'm at is Coastal Vision. I did my medical training at Boston University. I did an ophthalmology residency at UC San Diego, and I did a cornea and refractive fellowship at UCLA Stein. And if you're asking yourself, what business does a cornea specialist have giving a glaucoma talk, there's a slide specifically for that. But as we know, glaucoma and cornea, they interact a lot, especially when it comes to eye drops and ocular surface disease and such. So if there's something I can do as a cornea specialist to help with glaucoma without compromising ocular surface, I'm going to be all about that option. So in terms of the talk today, it's going to be 40-45 minutes or so. We're going to do a general introduction to glaucoma. I apologize in advance to my optometry and ophthalmology colleagues because some of this information is probably going to be very basic or repetitive for you, but just to make sure everyone's on the same page, we'll cover some basics. Then we'll shift focus to SLT, laser trabeculoplasty. We'll do some introductory slides. We'll talk about how this technology works, what clinical outcomes you can expect, and SLT in clinical practice, plus some cases, and that's where we'll spend the bulk of the talk on. And hopefully you'll leave with viewpoints about SLT or why we're very excited and use it all the time in our patients. So here we go. Glaucoma, as you all know, it's a very common condition. 70 million people globally, with approximately 10% bilaterally blind. So that's a big number when you think about it. It's the leading cause of irreversible blindness worldwide. Now I know every different kind of talk that you go to, the retina doctors say AMD is the most common cause of vision problem. The cataract doctor says cataract. But when you look at irreversible blindness in the world, glaucoma is actually the leading cause, unfortunately. Prevalence of glaucoma is projected to increase by 140% from 3.3 million to 4.7 million. Now again, these numbers are really large, but what strikes me is that when I was in the very beginning of my training in medical school thinking about ophthalmology, that 3 million number was 2 million. So now I'm just into practice few years, and it's already went from 2 to 3, and it's going to go even higher. And that's what really stood out to me when I was preparing this talk. As we all know, the normal physiology of the eye, the way things are supposed to work, is that the aqueous humor is made from the ciliary body, and it makes its way through the pupil, and it goes to the trabecular meshwork. So I'm going to use an analogy, just our simple kitchen sink. You have water coming in, you have water coming out, and as long as the amount of water coming in is equal to water going out, the pressure is physiological. We're not going to have any problems. The problem is when there's a blockade somewhere in the system. And as you all know, again, there's two broad categories. We have open angle glaucoma and closed angle glaucoma, depending on where this blockage is. With open angle, anatomically, when we look at the angle, which means the angle between the cornea and the iris, it's open. So theoretically, this aqueous humor can go. The problem with open angle glaucoma is that the blockade is further down in the trabecular meshwork. And that's important because that's exactly where SLT works, and we're going to talk about that. The other route is closed angle glaucoma, which means this angle, the angle between the iris and the cornea, is closed, so the aqueous humor cannot even reach the trabecular meshwork. So that's a completely different problem. Again, we all know that primary open angle glaucoma tends to be a lot more common, at least in America, both Northern and Southern America. And in Asian countries, the closed angle glaucoma might be more common than the rest of the world. But still, primary open angle glaucoma is the leading cause of glaucoma. So what's the big deal about having high eye pressure? How does that end up affecting our eyes? Well, there's a structure in the back of the eye right next to the sclera where the eye nerve exits called lamina cribrosa. And with high eye pressure, two things happen. This lamina cribrosa gets thinned and it gets pushed posteriorly. And it's the combination of the thinning and the posterior disposition of this lamina cribrosa that these axons, these nerve cells trying to connect the retinal ganglion cells to our brain, that they get damaged. So that's basically a 101 introduction to glaucoma. And what happens when we lose these healthy cells? Well, we get the cupping. Here's a normal cup to disc ratio to a high cup to disc ratio, and as a result, we get visual field loss, and that's the definition of glaucoma. So when it comes to management, if you look at all the different options we have, eye drops, lasers, surgeries, you can really divide them into three simple classes. All the options can really be divided in one of these three or a combination of both. You know, to bring the eye pressure lower, option one is to make less of the fluid, so aqueous suppressants. A lot of the eye drops tend to be aqueous suppressants. If there's a blockage, we can remove that blockage. So a lot of minimally invasive glaucoma surgeries, mixed procedures have to do with this. Some eye drops remove the blockage, and SLT, as we will get into, this is the mechanism through which it has its effect. And lastly, we can just make a new channel. And these are your tubes and trabs. And this is usually when we've tried to reduce the fluid production and it didn't work or it wasn't enough. We removed the blockage and that was still not enough or it didn't work. And we're, the only other option we have left is creating a new channels. Obviously, that's not a magic pill either. It has its own problems. It's usually in the form of a surgery, and it can have its own side effects. Now, those are the three general broad categories of ways to bring eye pressure down. There's three methods we can use. You can either have your eye drops. We're familiar with the aqueous suppressants, the prostaglandins, and it seems like every year there's an addition to that, and they work for the right patient. There's SLT, which we're going to talk about a lot in this presentation, and then the tubes and traps, so the surgeries. So, if eye drops were a magic pill, if they completely fixed the problem without a lot of cost, SLT or ALT before that would probably never even been created. Every technology we have is because whatever it came before that had problems. And eye drops are not without them either. So when you look at the most common eye drop prescribed prostaglandins like latanoprost, the most common side effect is conjunctival hyperemia. You can read the list, and again, a lot of you are familiar with the ocular side effects, and other eye drops have systemic side effects. For example, beta blockers. If your patient has a history of smoking, COPD, or any lung issues, you're probably going to stay away from it. With carbonic anhydrase inhibitors, if they have sulfa allergies, you're going to stay away from it. Alpha adrenergic agonists, they also tend to have a lot of ocular surface disease side effects. And again, as a cornea specialist, guess who sees all these patients where they're not happy? It's probably a specialist like me. Calling it dry eyes, ocular irritation, when this could have been better managed by a different eye drop or other options like laser. So this is why the industry and the medical instruments, they even thought about creating something to solve this problem. Now, what if we prescribe eye drops? This has been extensively researched that half of patients with glaucoma do not take their medications as prescribed. So it's one of those things where if they take the medicine, they're going to probably be dealing with the side effects, and they're going to be calling our eye offices. And half of them don't even take it the way they're supposed to, and that's obviously not ideal either. So again, I'm going to focus a little bit on the ocular surface side effect of things on the cornea because I see these patients all the time. So this has been studied, looking at patients that got anti-glaucoma drops and looking at how they did with their dry eye and cornea. So in this study, there were different groups of patients. There was the control that got nothing, preserved beta blocker, timolol in this study, preservative-free timolol, prostaglandin, and these last two groups are a combination of prostaglandin and timolol. And just look at the breakup time. So breakup time means the time it takes for a tear to break up on the surface of the eye. The higher this number, the better. So that means the higher the number of seconds that tear ended up staying on your eye as opposed to being, breaking up or evaporating. So with the control group, you see it's about 11.3. As soon as you add timolol, see this number goes to 8 seconds. So that ends up affecting their ocular surface. With preservative-free, goes back up to 11. So we know a lot of these side effects tend to be from the preservative in these eye drops, the timolols, the latanoprost, all of that. And then all these other numbers get worse from there. So this is why eye drops are a problem. Now this study did something interesting. They actually did confocal microscopy looking at the innervation of cornea. And here's the control patient. You see all these healthy corneal nerves with some tortuosity. This is how things are supposed to look like. Compare this to when that patient took timolol or latanoprost. With the latanoprost example, you see that these nerves are much less. And with timolol, you see they're less, and the tortuosity is just different from how the control looks. And we think this has to do with how the cornea senses, neurotropic keratopathy, and that ends up leading to dry eye and ocular surface problems. So this is the background to why, the industry, us as eye care professionals even thought about alternatives, and SLT. Hopefully by end of this talk, I can convince you that's a great alternative. In fact, in my opinion, is better than eye drops, and we'll talk about it. So selective laser trabeculoplasty, or SLT, was introduced in 1995. In this country, United States, was FDA approved in 2001. And it's been more and more popular ever since it was FDA approved. For example, in 2001, it was only used about 70,000 times in the Medicare population. Compare that to 2012, 142,000 times. So I don't know what the number is for 2020, but probably even more than that. And it has to do with the ease of the procedure. It's a short outpatient-based procedure with quick recovery, and it's safe. So it's really meeting all the requirements for a procedure that eye doctors look at. In terms of mechanism of action, the laser essentially is going to target melanin cells, these pigmented cells we all have in the trabecular meshwork. And what that does, it's almost like irritating this tissue. So in response, the eye makes macrophages, which are inflammatory cells, and other inflammatory markers like cytokines, MMPs. And what these inflammatory cells will do is that they will essentially smoothen or make pores and openings in the trabecular meshwork, such that by the end of this process, there's a healthier, more porous trabecular meshwork that the aqueous humor has an easier time being drained through. That's how we think SLT works. So this has been studied, of course, just to prove, is it that, the aqueous humor production becomes less? Is it that we're removing the blockade? And there's a very nice paper in IOBS that nicely proved the mechanism of action of SLT is increasing the outflow of aqueous humor. So we're essentially removing the blockade. And this works nicely, and I think everyone who uses SLT should know this, because if you need to supplement SLT with another procedure or drop, you know to go after something else. If you've already removed the blockade, maybe you can use an eye drop or another procedure that's going to go after suppressing the amount of fluid production, as opposed to doing another procedure that was just going to block remove the blockade, which we've already done with the SLT. So it's important to know the mechanism of action. Here's a nice animation on SLT. So as we just talked about, basically the laser engages these melanin pigmented cells, and they produce the inflammatory cells, the macrophages, and that's how we think SLT works. Here's a video we actually took with the help of LIGHTMED and Advancing Eye Care this week. This is just from a few days ago. And the red light is where the laser is aimed at, obviously. You want to go between the pigmented and non-pigmented trabecular meshwork. I aim towards the pigmented trabecular meshwork. And you adjust the laser. We're going to talk about that in a few slides, but essentially you want to start seeing some of these bubbles. We're going to go to the beginning of the video since it showed that really nicely. You want to have enough energy to create what we call micro bubbles, and that's the energy at which you know you're treating the patient properly. The most important part is having a good visualization of the angle. If you can't even see the trabecular meshwork, that's a problem. So that would be a patient with closed angle, for example. So I would say number one is visualization. This patient has a particularly pigmented trabecular meshwork, so it's really easy to see it, and therefore aim the beam. And then you essentially just want to go until you see the bubbles. And there's going to be another video on this. Now, SLT is not the first laser created for this purpose. Before SLT, we had ALT. Now, in my training, I haven't even seen ALT. It was way before my time. But ALT stands for argon laser trabeculoplasty, and I'm not aware of anyone that uses this technology anymore. SLT has pretty much replaced ALT because, number one, it's been shown to be as effective, if not more effective than ALT. And number two, and probably more importantly, it's less traumatic to the trabecular meshwork. So here's a histopath slide of the ALT. You can see the amount of trauma, like a crater that this laser created, almost like a mechanical and from heat trauma that made through the trabecular meshwork. And this is why with ALT, the data shows having IOP spikes was more common, having uveitis or reactivating uveitis was more common. Compare that with SLT, you can barely notice anything was done. So in this study, they called these trabecular meshwork cells having crack-like defects. But if I didn't tell you anything was done to this eye, this otherwise looks like a normal trabecular meshwork. So that's why, going back to the mechanism, we don't think it has to do with the thermal or mechanical energy of the laser. We think the mechanism is more at the cellular level. It's the inflammatory cells that get engaged, the macrophages and such, that end up smoothing the trabecular meshwork. So then the question is, okay, this sounds great. It's a quick procedure in office. What kind of a response can I expect for my glaucoma patients? Well, as you know, first of all, for the overwhelming majority of glaucoma patients, if they've never been treated, we probably want to decrease their pressure by 25 to 30%. That's on the practice guidelines of the American Academy of Ophthalmology website. 25 to 30% is a good starting point. So if you're starting with a pressure of 20, having 20% less than that would be having pressure of 16 or so. So that would be a good starting point. So having that in mind, what kind of pressure lowering can we expect from SLT? Well, it depends on the time range, but when you look at the reviews, which looked at many papers over the years, you can probably expect 20 to 30% depending on the time range you looked at. So 6 months, 20 to 29%. At 1 year, 16 to 30%. That's a wide range depending on the study you look at. 2, 3, 4 years, most of the studies say still 20, 25% to 29%, which is why all these years we thought of SLT as equivalent to the prostaglandins. With prostaglandins like latanoprost, that's the IOP reduction that we expect, about 25 to 30%, and SLT is right there with it. Now, up to this point, most of the studies argued that SLT is just as good as eye drops when it comes to lowering your eye pressure. For example, many studies looked at SLT, comparing it to the most common eye drop we prescribe, which is latanoprost, and it showed that it's only as good as latanoprost, but not necessarily better. I'm going to show you data that argues otherwise, that argues SLT might actually do better than eye drops when you look at these patients long term. So this is a landmark study. I'm going to spend a little bit of time on this. I think this study is probably the most important one in this talk. It's called the LIGHT study. It was done in the UK, and they did something interesting. They took primary open angle glaucoma patients and ocular hypertension patients, and they divided them to drop first and SLT first. For the first time since SLT was introduced, these are patients that never had any other treatments. So, this is their first visit that someone tells them you have glaucoma or high eye pressure and you need IOP lowering, and they've never been on any other drop. Every other study you look at, they put these patients through a washout period, but they've still been on a drop before that. And the results are really interesting. What percent of patients of those who got SLT only needed one SLT? And by the way, the duration of the study was 36 months, so 3 years. So by the end of 3 years, 74% of these patients only need one treatment. This is interesting because we think of SLT as a procedure that its effect wears out with time. If you see the patient next year and the year after that, the chances are the pressure might creep back up again, or you might need to supplement it with a drop. In this study, which was a really well-designed study, most patients, 74%, they only needed one drop. The most important number in this slide is this 78%. What percent of patients who ended up getting SLT reached that 36 months, so 3 years into the study, and they never needed any medicine? 78%, that's a big number. This is the number I keep in mind when I have the patient in front of me in clinic and I want to start either an eye drop and SLT, and I tell them there's an 80% chance that if we do SLT and we see each other in 3 years, you would have not needed any other eye drops. Think about the number of times you have to call the pharmacy, the cost of the medicine, the number of times they have to come in for eye pressure checks if you're on eye drops, all the side effects that they're going to have in these eye drops. So that's a big number. When you look at what percent of visits during these 3 years were these patients at or below the pressure that was set for them? In the SLT group, 93%, in the eye drop group, 91%. And that makes sense. I mean, eye drops do okay, but compliance is obviously an issue. So more visits in the eye drop group, the pressure was not where it needed to be compared to SLT. And at end of the 36-month period, what percent of patients were at the pressure we wanted to be? 95% for SLT, 93% for the eye drops. Another really important number, which group had a higher chance of their disease progressing? So they got the treatment, they got to the pressure we thought was the right pressure, but despite that, they still had worsening of their glaucoma. 3.8% with SLT, 5.8% with eye drops. Again, it probably has to do with the compliance. And the last number that is really important to me is how many patients in the SLT group ended up needing a surgery like trabeculoplasty or trabeculotomy? 0. So none of these patients ended up needing a surgery, but 11 of the eye drop group ended up needing it. So the takeaways for me for this study were that by 3 years, it showed that the percentage of patients requiring no eye drops was 74%. In the SLT group, 93% of the time, the pressure of the patient was at or where it needed to be, compared to 91%. And again, the most important for me is what were the chances that this patient needed a surgery? With SLT, none. With the eye drop, 11 patients. So this paper concluded, number 1, SLT is safe and effective as first-line treatment for open angle glaucoma and ocular hypertension. SLT provides superior IOP stability at a lower cost. So this is, again, the first time that this paper showed that, yes, we knew that SLT does a great job with bringing the eye pressure down. Yes, it makes intuitive sense that it's more reliable. And yes, it's going to cost less, and it's more convenient to the doctor and for the patient. But it's the first time that it showed patients in this group did better overall. It was superior to eye drops. And again, this is the only study that has shown it, and it's a landmark study, so that's why we put a lot of weight on it. And almost 3/4 of the patients in the SLT group were successfully controlled for at least 3 years without ever needing an eye drop. Now that's from a medical standpoint. So, you know, my takeaway from this study is that even if SLT was the more expensive option, even if SLT was the less convenient option, based on this, and since medically it was the better option, I would have chosen SLT as my first option, even if it cost more and it was less convenient. Well, thankfully, it's the more convenient and less expensive option. So, for example, if you look at drops versus SLT from a practice flow and practice management standpoint, think about all the steps that you need for the eye drop. So you're the doctor, you decide your patient needs to be an eye drop. You're going to call that to the pharmacy. Well, number one, will the insurance cover it? You don't know. You prescribe it, you hope it's covered, and a lot of times it's not covered. Step two, the pharmacy has to carry it. I remember a few years ago, there was a shortage of some of these glaucoma drops. So we were getting all these calls at my residency that, you know, no pharmacy has this eye drop that we need. What do we do? So that's the second step. And the third step is the patient actually getting it. And step five, using it. And even if they use it and they have side effects and problems, guess who they're going to call? This is all going to come back to you, and this circle is going to start all over again. So all these steps are needed. Now, when I'm starting an eye drop, I prescribe it. My front desk will order it to the pharmacy, and I'm not going to see this patient for another 6 to 8 weeks. And I just hope and assume they got the medicine, they used it as prescribed, but it ends up being half the time that they come back at 2 months and they tell me, well, it was not covered and no one called us, no one told us, and I thought you guys would just know. So there's opportunity for miscommunication and not being properly treated. Compare that with SLT. You're the doctor, you're in clinic, the patient's right there in front of you, and I yet have to have a case of SLT that was not covered by insurance, so almost always it is covered, and you're in control. You can make sure that the patient's in front of you, you do the treatment, you know how much you treated, and it's all documented and it all happens in your office. You have 100% control over this. And that's the most important thing when it comes to a chronic disease management like glaucoma, having control over the treatment. Now the same study from UK, they looked at, you know, what if patients got SLT, they came back a year or two later, the pressure went back up again. Could we retreat them, and how did these patients do? And this was published in Ophthalmology, and they showed that yes, repeat SLT can maintain IOP at or below the pressure that you like it to be. So that's the other nice thing about SLT. If you don't get enough response that you want, or you do get the response and the patient comes back and the pressure is not, you know, it's going back up again, you can repeat it. So this all leads to why SLT is my first choice. I hope I've done a good job convincing you with all the data I presented why I go to SLT first. Number one, you know, we already had evidence that, you know, it's at least as effective as eye drops when it comes to lowering your pressure. But now we have data that when you look at patients that got drops versus SLT, the SLT group had superior IOP stability compared to eye drops, and that makes sense. You know, even if the eye pressure is where you want it to be for the eye drop patients, it is possible that the patient didn't take it in between the last visit and this visit, and they knew their appointment is coming, so they just started taking it again, and the pressure looks like it's where it needs to be. But then in between the visits is where the pressure is not controlled, and that's probably why these patients ended up needing more surgeries than the SLT group. So the IOP stability is superior with SLT. It doesn't depend on patient compliance. You don't have to worry about it. You don't have to ask them, Mrs. Jones, are you taking your eye drops? Not, why not? Was it insurance? Was it the pharmacy? And usually it's a combination of both, or it's honestly hard to ask someone to use an eye drop in their eye every day for the rest of their lives, you know, once or twice a day. It ends up actually being pretty difficult. It's very safe. It's repeatable. It's definitely cost effective for everyone involved, for the doctor, for the patient. Imagine all the copays and money that they have to spend on the eye drops, and the healthcare system as a whole. And you get less ocular surface side effects, which is the part that I really care about as a cornea person. So who's a great candidate? Anyone with an open angle that I can see the trabecular mesh work is a great candidate. The higher the baseline pressure, the more the effect of SLT I expect. So I'm going to get more IOP lowering in someone with pressure of 25 and someone with pressure of 15. So I'm going to take that into account when I'm making this decision. The more pigmented the trabecular meshwork, the better. Anyone with poor ocular surface, someone that the ocular surface is already beaten up, I don't want to throw a glaucoma eye drop on it, SLT is a great option. And any patient that you just know they're not reliable, they've missed few visits, you've had them on few drops, compliance is an issue, that's exactly the type of patient you want to do SLT on. There's almost no absolute contraindication to it. The only ones I can think of is if the patient is just physically not able to sit at a slit lamp to do the SLT, but then if they can't even sit at the slit lamp, what are the chances they're going to use their eye drop as the way they're supposed to? So I really tried hard, even for those patients, to position well. Theoretically, if they've had a history of uveitis, you might have a reactivation of uveitis after SLT. I yet have to see this. Or if the trabecular meshwork view is not good, whether either because of synechia or closed ankle or any other reason. The procedures in terms of things you need are very simple. You basically numb the eye. The patient just comes in, I measure the vision, my staff do it for me. They sit in our laser room. We just put a drop of proparacaine. I'm going to have my gonio lens ready, and we're going to put some gonio gel on it, and that's it. Believe it or not, of course, in addition to the SLT machine. But that's these are instruments you already have in your clinic, so it's not going to be hard after that. Now SLT uses short pulses of low energy, specifically for all my engineering friends, 532 nanometer Q switch, frequency doubled ND YAG laser. And there's few things you can control. The one that you cannot control is the spot size. For every SLT machine that I'm aware of in the world, the spot size is 400 microns. The parameters that you do have some control over is number of shots, so you can decide if you want to treat 180 degrees or 360 degrees. So I typically do 180 degrees, which would require 50 shots. That's 25 shots per quadrant, but there's no reason not to do the whole 360. I usually do the inferior half, inferior 180% degrees. And then if I need more SLT, I go after the superior trabecular meshwork. And then the last thing you can play with and adjust is the energy level. So I usually start at around probably 0.7 or 0.8 millijoule. And I look for these micro bubbles. I want to increase my energy until I see some of these bubbles that you see in this video. And that's probably the energy that's adequate. So we're 40 minutes into the talk. Let's just cover a few cases. Case number one, this is actually from a few months ago, before the pandemic started. A 52-year-old African-American lady came for a glaucoma evaluation because her parents, I think her mother had glaucoma. The only other past ocular history you should know is she had LASIK, and her uncorrected vision was excellent. She was seeing 20/20, kind of scratching her head. Why do I need to be checked for an eye disease if I see 20/20? On exam, I could see the LASIK flap. Her cornea was really thin, but she had a myopic LASIK treatment, so that's why. But that's important to know when you think about the eye pressure. So very thin cornea, the angle was open and was pigmented. And the cup to disc, it didn't look horrible. I could have not taken pictures of that, put it in a glaucoma textbook and call it glaucoma, but 0.3 and 0.35. We did the glaucoma workup, and that's where things started to show up. On the RNFL OCT, you see thinning superiorly on the right RNFL and some borderline thinning in the left eye, which corresponded to our visual field test. So both eyes had nasal steps, which was very unfortunate because this is a very young patient. And as I told him, we really don't want your eyes to get any worse because you're so young. You need your eyes for at least another 40, 50 years, if not more. So just in summary, this was a case of mild primary open angle glaucoma. First visit that I saw her was 15 and 16. I usually take 2 baseline pressures just to make sure the numbers are stable. So mid to high teens, excuse me, pressure for this patient. So the options we had, the one that we almost always have, drop versus SLT. And some considerations was stage of glaucoma. So this was mild. This is not a moderate or advanced case, but this is a very young patient. I don't want her to progress at all. And ocular surface. Now with LASIK, some doctors talk about dry eyes and ocular surface disease. So I also thought about, number one, do I want to throw a glaucoma drop to someone who's had LASIK? And number two, this patient is really young. If I commit her to eye drops, we're talking about eye drops for another 30, 40, 50 years. Imagine the effect of that on the ocular surface. So because of that, and after explaining what SLT is, we ended up doing SLT, 180 degrees in both eyes, and we got an excellent pressure response, 10 and 11 from mid-teens. And we're just following her and hope she will never need any eye drop. Second and last case, 68-year-old Hispanic male, came for a follow-up visit. This is a patient I inherited from the doctor that was in the community before me. He has since left. This patient had missed 2 visits, so already I knew maybe not the best compliance in the world. In terms of past ocular history, he was phakic and he did have cataracts. His best corrected vision was about 20/30 or so, but he was still happy with it. Didn't really complain about vision much. On exam, I saw nuclear sclerotic cataracts. He had an open angle with 1+ pigmentation, average cornea thickness, 530, 540, and some cupping. He had 0.5 or so cup to disc ratio, as you see in these pictures, right eye and left eye. And when you look at the OCT, the left eye is a good quality OCT, and you see thinning, inferior on NFL. The right eye, there's parts of the image that have poor quality. So it's possible it was because of this that the inferior quadrants is showing red, but the superior part, the quality was great, and it still showed some RNFL thinning. So I believe that this is true glaucoma. And of course, you're going to follow it up with visual field tests, both of which were reliable, and already having a superior arcuate defect, inferior nasal step turning into an arcuate defect. So this patient I thought had moderate primary open angle glaucoma. Again, this was a patient seen in our community for a number of times. It was puzzling to me why nothing had been done for him before. But I had about 6 visits data in terms of the eye pressure, and they were all between 21, 22, 20, 22 or so. So what do we do? Well, the options are drops, SLT. Given that this patient had cataract, another option is to do cataract surgery with MIGS, minimally invasive glaucoma surgery. So consideration, stage of glaucoma. Again, this patient is moderate stage. He's actually young in the glaucoma world, so I really don't want him to get any worse from where he is. And stage of cataract, I would call the cataract mild. And compliance, this is a patient that missed 2 visits. So if we prescribe an eye drop, what are the chances that he's going to actually take it? Probably less than 50%, assuming it's covered and everything. So we ended up doing SLT in both eyes, and pressure went from low 20s to 17 in the right and 15 in the left. And I'm happy with that pressure, and we're going to follow him with that pressure in his glaucoma stage and see where we end up at. So this is a summary slide. I tried to divide reasons why SLT is very popular from the doctor's standpoint and from the patient standpoint. For the doctor, short learning curve. If you do any procedure, if you're a surgeon, this is probably the easiest procedure ever in all of ophthalmology. Even compared to other laser procedures like a YAG capsulotomy and other laser procedures, this is probably the easiest in-office laser procedure. From patient's perspective, it's quick and it's in office that they're used to and they're familiar with. As a doctor, you're going to be in control, and as a patient, there's less medications that you're going to be dealing with. That translates into less visits to your clinic. Some of these patients, you have to see them 4 or 5 times a year. That adds up if you're a high volume clinic. And for the patient, especially with COVID, no one wants to go outside their home. So the more you've had the IOP controlled, the less they have to come and visit the doctor. It's reimbursed really well. At least I can speak on the United States. It does really well. And from a patient's perspective, all the money that they have to spend on eye drops on the many years ahead of them, hopefully that gets saved. It's very safe, less complications, and almost 30–40% of patients that I start them on an eye drop, I almost wait for that phone call a few weeks later that, I got the eye drop, thank you, but now I have burning, now I have itching. So again, it adds up. The phone calls in your office will start ringing more than what they should for not the right reasons. Yeah. Can you just repeat the last part of the question about the IOP of 50?
Yes, I think, for example, and I'm just paraphrasing here, but for example, if somebody has a very high IOP of 50, does SLT work?
So, the first step in glaucoma management is setting a pressure goal, right? So for a patient that their pressure is 21 and I don't see any evidence of glaucoma, I might be okay with doing nothing. For a patient of pressure of 25 that I do see evidence of glaucoma, depending on everything else involved, let's say we're going to set a pressure goal of high teens, like 19, 18, something like that. So once you have a pressure goal, then the second step is how are you going to get there? Drops, SLT, or surgery? And what are the likelihood of you getting to the goal that you want? So for overwhelming majority of patients, you're thinking of eye drop or SLT. In fact, the higher the eye pressure, the higher the chance or the lower your eye pressure reduction will be. So again, as I said, doing SLT in a patient with pressure of 30 will have a much higher response than in a patient with a pressure of 12, for example. Now, in this, the specific question was, let's say someone's pressure is really high, 50. Well, someone who has a pressure of 50, that's not just some open angle glaucoma. They might be an acute angle closure attack, might be a lot of other things, but the pressure goal of someone with pressure of 50 is not going to be just 20% better or 30% better at best. If the pressure is truly that all the time, you're probably looking at surgery. So for that specific example, I would figure out why the pressure is 50. Pressure of 50 is not normal, might be a glaucoma attack, but that's not a patient you're thinking SLT for. But when we talk about high eye pressure in the open angle glaucoma world, we're talking about mid-20s, sometimes 30s. Yes, you can by all means start with SLT, and if you get to your IOP goal, great. If not, you can either repeat it or go to eye drops. But think of all these options as tools that they're going to get to pressure that you want to get to.
Perfect. Thank you so much. I'm going to go to the next question now. What percentage drop is seen with SLT in a patient already on a PGA?
That's a great question. We know that every time you're on an eye drop already, obviously that's going to bring your eye pressure lower because you're obviously on the drop. And the lower the pressure gets, the less efficacious the SLT. So, another way of saying that is, let's say you have two patients, or same patients, different, the right eye and the left eye. One eye is on latanoprost, one eye is not on latanoprost, and you end up doing SLT on both eyes. You're going to see a better response on the eye that was not on latanoprost, which is why I tend to start it first anyway before putting them on any eye drops. So what is the exact percentage? There's no magic number, but when you look at studies, it's going to range between 15 to 20, 25%, which is less than the 20 to 30% in a prostaglandin naive patients. So still has an effect, still has a role. In fact, before seeing the LIGHT trial results and before being more familiar with SLT, that was probably what I did. Start patient on a latanoprost. If I was not happy with pressure lowering enough, then I would supplement it with an SLT. And majority of eye doctors, that's probably what they used to do. Start an eye drop first, then SLT. And given the new data that I just presented, I hope I convinced you to do SLT first.
Okay, so I guess in addition to that question, what percentage of drop is seen with a PGA added after SLT?
Similar answer. You're going to get less. So regardless of if you start SLT first or an eye drop first, whatever comes second is going to have less effect than if it was the first step. So if they get SLT first and you start them on latanoprost, how much reduction do we expect with latanoprost in someone who has not had SLT? Well, 25 to 30%, just like SLT. But when you do that after you get SLT, it's probably going to be less. It's going to be 20 to 25% from where you are at that point, because the SLT has hopefully decreased the pressure some.
Perfect, thank you. When SLT wears off, how quickly does the IOP rebound? So basically, how frequently do patients need to follow up?
Traditionally, the thought process was by a year, year and a half is where we start to see the IOP coming back up again. There's a wide range, in answering that question when you look at the studies. Again, my go-to study is the one that I presented, the LIGHT trial, because it was just really well designed. And it shows that a lot of these patients, how many is a lot? 74% or so, reached 3 years and they only needed one treatment. So this study really argues that it's possible for overwhelming majority of your patients, 74% or so, to go drop less, to go without ever needing another treatment with SLT up to 3 years. But you're gonna obviously not just gonna do the SLT, say goodbye, and see them in 3 years. You're gonna keep monitoring them. Now, how frequently you're gonna monitor them depends on the stage of the glaucoma and their age. Let's say for your average 65-year-old with mild glaucoma, I'm gonna do the SLT. I'm gonna see them in 6 weeks or so, make sure the pressure is where I need it to be, and as long as I get to the pressure I want, I'm gonna see them twice a year. And I'm gonna go up in terms of number of visits, the more advanced the glaucoma gets. So if they're moderate glaucoma, I'm gonna see them 3 times a year, like in 4 months. Advanced glaucoma, I'm gonna see them 2 to 3 months.
Perfect, thank you. Are there any patients that SLT is contraindicated?
So let me see if I can find, we had a slide on that. So probably the biggest category of contraindication or inability to do LASIK, I would say, is positioning the patient behind the slit lamp. And these are your patients that come in a wheelchair. They have difficulty getting into the slit lamp. They have difficulty putting their head up against, to properly position their head. These are exactly the same patients that you're not going to be able to sit properly at the slit lamp and get a good view of the angle. So I would say this is probably the most common reason to not be able to do SLT. If anyone has any significant history of uveitis, so let's say they have HLA-B27 uveitis, SLT can potentially reactivate their uveitis. So if I see a young patient with glaucoma with recurrent evidence of uveitis, I will probably stay away from SLT. I would say this is a relative contraindication. It's not an absolute contraindication. And any patient that you put the gonio lens on and you just cannot see the trabecular meshwork. And that's obviously crucial because you want to aim your laser beam to the trabecular meshwork. So if you can't see the trabecular meshwork, obviously you're not going to do this procedure because it's not going to be done properly. So anyone that you cannot see the trabecular meshwork should not get SLT.
How do you decide whether you're going to perform a 180-degree treatment or 360?
I think it's a matter of doctor preference. Obviously, as you can guess, it's been studied. So when you look at the studies, there's a good body of evidence that showed doing it 90 degrees, 180 degrees, or 360 degrees did not make a difference in terms of pressure lowering. There's another interesting study that started with the lower 180 degrees of the eye, and if they needed another SLT, then they divided patients to 2 groups. They retreated the same area they already treated with SLT, so the lower part again, and then the other half of the patients, they got the superior part that was untouched. That's the laser they got. And the paper showed that they got the same exact response, which tells you it probably does not have to do with the degrees or how many times you go back to the same area and treat. And that goes back to the mechanism of action. We think it really has to do with the inflammatory markers, with essentially almost like scratching the trabecular meshwork, if you will, and the inflammatory response, and having the mechanism of action at a cellular level as opposed to the ALT slide that you saw. So how do you decide? Again, it's surgeon preference. I almost always do 180 degrees only. If I need to do a supplement SLT, then I go to the superior part. Again, based on the study I just shared, I can't just go back to the same area I already treated and I should get the same response, but to me it makes more sense to treat the area that I have not treated. The only study that showed doing SLT 360 degrees is better than 180 degrees is a study that compared different angles to treat compared to latanoprost. And that study showed that patients that got 360 degrees were comparable in terms of pressure lowering to latanoprost, but then the 90 degree and 180 degree, they were not as good as latanoprost. So that's the only study I'm aware of that argued doing it 360 degrees is better. At the end, it's doctor's choice. My preference is 180 degrees, and I can always supplement it.
So when you do apply these shots at those different 180, 360, how exactly do you do it? Is there a certain place that you start, position the lens, and do you go counterclockwise or clockwise, or does that matter?
So that's a great question. So here's a view of the inferior angle. So my light beam is, as you know, the gonio lens has a mirror in it. So my light is shining the superior mirror. And because of that, I'm getting a view of the inferior, the lower trabecular meshwork. So I start at 6 o'clock. I go all the way to 3 o'clock. I come back to 6 o'clock, and then I go from 6 to 9 again. And you're going to need 25 shots per quadrant. So, this laser machine shows you how many shots you've already applied. So I start at 6 o'clock. I go 25 shots to 3 o'clock. Then I come back, start at 6 again, and I count another 25 shots from 6 o'clock to 9 o'clock, and that covers my inferior 180 degrees.
Perfect. What is the typical learning curve to get proficient at SLT placement of treatment?
I guess the best way I can answer that is when I was a first-year resident, my senior resident showed it to me once, and that was it. So after that, the expectation is you're going to know how to do it. I would say just like MIGS surgery, the surgery part is very easy. Same with this. I mean, you're basically clicking on the SLT machine and it applies it. The trick is the angle visualization. If you have good visualization, it's going to make everything easy. Again, just like MIGS. So I would work on your gonio skills. As a resident, I would gonio every patient who would walk in, even if they didn't have any glaucoma problems, because I think it helps to also see what normal angle anatomy is supposed to look like before you can tell what abnormal angle anatomy looks like. So I would say work on your gonio skills, and I would argue SLT skills really all relies in your gonio skills. If you have good visualization, the rest of it is just clicking the button and then the laser applies.
Perfect. And the next question, actually, I'm going to go ahead and ask and answer because this applies to us. So they're asking about the inquiry of the phone camera system that was used. And Dr. Marvasti, as you know, that this camera system took one of the best footage that we've ever seen for SLT, and it can be inquired through LIGHTMED. Anybody in the international market and in the US, you can inquire that from Advancing Eye Care directly. So we both do sell this product, and it does work with the iPhone, certain models only, I believe about 6 to 8, and then the 10, the newest model is just released. And it does actually work on a lot of other slit lamps. So for more information, you can contact sales@lightmed.com or contact your local representative at Advancing Eye Care. So I'm going to move on to the next question. Oh, sorry, go ahead.
No, I just want to add to that and say I was really impressed with the quality of the recording and the pictures we were able to take. You know, I work with optometry students and residents, and you always want to show them videos of how things are supposed to look or how a procedure is supposed to work. And with SLT, it's really hard to find a video. So this video that we showed in this presentation might be one of the best videos I've seen, at least for this procedure. I added it to my social media, and the response was overwhelming.
Perfect. Thank you so much. Okay, so back to some clinical questions. If you see a very lightly pigmented trabecular meshwork, would that dissuade you from SLT and push you towards drops?
The short answer is no. The only difference it's going to make for me is what energy settings I start with. The more pigmented the trabecular meshwork, the less energy you need. Again, think of these pigmented cells in trabecular meshwork. If you clinically see a lot of pigments on your gonio exam, then you know there's going to be a lot of these melanin cells. So you're not going to need a lot of energy to activate them. So the higher the pigmentation, the less energy I'm going to use, and vice versa. But if I see a angle structure that is not pigmented at all or is very minimally pigmented, does that mean SLT will not do as well? Absolutely not. You will just need more energy to get to the melanin cells that are there. There's just less of them.
Great. So this next question actually follows up to that. So when you perform SLT at the max of 2.0 millijoules, for example, and no microbubbles are seen, does that mean it's still effective or not?
I would say I've never had to reach 2 millijoules energy. So I would argue if you're on 2.0 millijoules and you're not seeing any bubbles, you're probably hitting the wrong structure. You're probably hitting the ciliary body or the Sampolisi line, which can be pigmented. It can look like a pigmented layer that might present itself as the trabecular meshwork. So I would say I would make sure you're treating the right location.
Perfect. So how do you treat patients with pigmentary glaucoma or a history of uveitis? Do you lower the intensity and or number of shots, and by how much?
So pigmentary glaucoma and pseudoexfoliation, yes, you would need less energy. So a good starting point would be 0.6 to 0.7. Let's see if I can find this slide. So I would start at 0.6 to 0.7, and you're going to increase that by 0.1 millijoule increments until you start to see some bubbles. So what ends up happening most of the time is I start at 0.6 or 0.7. I shoot at the trabecular meshwork. I don't see anything happening. I'm going to go up 0.1 millijoules. And I keep doing that until I see some of these bubbles that you're about to see here. With uveitic glaucoma, a lot of times these patients have synechia, so the angle is somewhat closed. So there might not be great candidates for SLT. And we also know that having uveitis, particularly evidence of recurrent uveitis, is a relative contraindication for SLT. So for uveitis, I stay away as much as I can from SLT, but that's probably the one exception that I would prefer drops.
Do you prescribe any drops immediately after the SLT for inflammation?
So that's a controversial topic. Let's just spend a minute on it. So the thought process is, okay, so SLT's mechanism of action is by inflammation. It's these inflammatory cells that attack the melanin pigmented cells, and that's how SLT works. So why should we dampen down the inflammatory response if that's in fact how SLT ends up working? And there's two schools of thoughts. One group says since the mechanism of action is actually causing inflammation, we should not give steroids. And the other school of thought is, well, there might be an IOP spike because you're liberating a lot of these pigmented cells, and they're going to actually clog the trabecular meshwork, and it might lead into a IOP spike in the minutes or hours after the procedure. And what's the correct answer? I think you'll find half and half doctors, some that do steroids, some that don't. I will also say that there's been 2 major studies. One showed that I think they had 40 or 50 eyes. Half of them got steroids after SLT, half of them didn't get steroids after SLT, and both did well. Both had no or minimal risk of IOP spike, and you looked at their IOP 6 weeks or a few months after, it was the same. More recently, there's a new study that came out. I think it's called SALT trial. I think the S stands for SLT or steroid. And it did a similar study. SLT, one group got steroids, one group didn't get steroids. And the only difference that it did show was that the group of patients that did receive steroids, they ended up having a better IOP 6 to 12 months later. So it did show that there is benefit in giving steroids. But again, you can basically find whichever answer you believe in the literature. There's evidence for both. And in my experience, doctors do it half and half. Me personally, I don't prescribe steroids. I tell my patients, you might feel a little light sensitive for the next few hours. If the light sensitivity, instead of getting better, it gets worse every hour or every day, call me and we'll prescribe steroids. I yet have to do this for any of my patients, so it hasn't happened.
With that said, do you have a post-treatment follow-up protocol, and how far apart do you space treatment on one patient?
So the second question, I usually space them a week or 2. I just want to make sure that if it has any IOP spike or any blurring or light sensitivity, it goes away before we treat the second eye, and it practically ends up being a week or 2. And then, I'm sorry, your first question is, what's my post-op protocol?
Yes.
So right after SLT is done, I'm going to put a drop of Durezol in the eye. I'm not going to prescribe any steroids to them. I'm just going to put a drop of Durezol. They're going to wait in that room for about 10-15 minutes. I'm going to check the pressure. As long as the pressure is not going up and we're not having an IOP spike, patient leaves. And if we need to do the second eye, they come back next week or the week after that. If that's the last eye we're going to treat, I'm going to see them in 6 weeks, 6 to 8 weeks. And that's when I look for the SLT results, and we'll see how they're doing.
Okay, how effective is SLT with LTG?
So it's less effective because LTG, as you know, stands for low tension glaucoma, and you're going to get less of a IOP reduction the lower the pressure is. So again, let's say you have 2 patients with glaucoma. One is at a baseline pressure of 12. One is at a baseline pressure of 25. The patient with pressure of 25 is going to get a lot IOP reduction with SLT. It doesn't mean that the patient with pressure of 12 is not going to get any response, but you can't expect high amounts of reduction. And by the way, that's the same with eye drops. The patient with glaucoma and a pressure of 12, it's not like they're going to have a significant reduction in their pressure with just eye drops. And it has to do with episcleral venous pressure. We're not going to get into all the details, but there's only so much you can bring your eye pressure down with eye drops and lasers because the eye has, it sort of hits the floor. And the floor pressure for most patients is what the episcleral venous pressure is. And that's somewhere between 8 to 10 or 11. So that patient with low tension glaucoma, they tend to be the toughest to treat because the pressure is already low, and it's hard to get it even lower with either eye drop or laser. So in my experience, if they get to moderate to advanced stages of glaucoma, they might be looking at a surgery.
Have you ever done an SLT treatment directly on the limbus, that is without use of a gonio lens?
So why do we use gonio lens? Because of total internal reflection. If I were to shine my slit lamp and try to look at the gonio, I will not be able to do that, which is why gonio lenses were created. So the answer is no. The only exception is people with megalocornea. Their cornea is so steep and so large that you do not get total internal reflection. You are able to see the angle structures without a gonio lens. I would still not advise doing it without a gonio lens. So for all intents and purposes, the answer is definitely no.
There is some good data on second treatments that may work better than the first. If you have minimal response, do you retry or go to a drop? And when?
There's no great data to know, okay, I have a patient that I did SLT number 1 and I didn't get as much pressure lowering that I wanted to. How much pressure lowering can I expect if I go a second round? I don't think we have great data, or at least specific numbers for me to share. But again, I go back to the same decision points. Okay, we did SLT number 1. Your pressure either did not get better at all, it's rare, or it got improved minimally and I need more pressure lowering. It's the same decision making as eye drops versus SLT all over again. With SLT, you have very little to lose. The insurance is going to cover it. It's going to be less costly than eye drops. And the alternative is committing this patient to eye drops for the rest of their lives. So when you look at the risk-benefit ratio, I still prefer to do a second SLT before calling SLT a failure and then switch them to an eye drop, because I don't think we have anything to lose. And besides few weeks that I'm going to do the treatment and wait a few weeks to see what kind of pressure we got. But thankfully, glaucoma is such a slow disease that few weeks is not going to make a difference. So I look for a reason not to do SLT a second time around.
Is there a limit to how many times a patient can receive the SLT treatment?
Again, in the literature, you're going to find as high as 3 or 4. I would say if you did the treatment once and you got a good response, and it's a year later, and the patient's back, the pressure's back up, there's no reason to think they're not going to have an amazing response again. So I keep doing as many SLTs as I can until I reach a point that I say, okay, now we've tried this SLT once or twice since your pressure came back up again, and I'm not getting the response I want. And at that point, I'm going to go flip to a surgery or to an eye drop. But I'm going to keep going until I see a good response from SLT. You're not going to do significant harm by doing repeated episodes of SLT. And that goes back to the ALT versus SLT slide. The amount of damage is so, I'm not even going to use the word damage because you really don't see any effect on the trabecular meshwork. Now, if it was ALT, obviously there's so many times you can keep doing this to an eye before you run into problems. But with SLT, theoretically, I would put a maximum of 3 to 4 times. But even if the, treatment number 3, treatment number 4, if you're getting a good response, there's no reason why not to do it over again. But it's usually after the 3rd or 4th time that you might not see the response you're looking for and switching them to an eye drop.
Okay, this next question is from a physician that says, if a patient had an IOP of 27 and was treated for several years with drops, and now you do a 2-week washout of drops, will you still get a poor response to SLT?
The answer is no. When you do a washout period, you're going to get a great response to SLT, and this patient's pressure is 27 with an eye drop. So I would argue I would actually keep the latanoprost or whatever eye drop they're on. Kind of depends on what's the pressure goal. But let's assume hypothetically the pressure goal is low teens or high teens or low 20s. I would probably keep the eye drop and just supplement it with SLT. Remember, I said you're going to get more response from SLT if you're not an eye drop. But that does not mean that you should necessarily take the eye drop they're on away, because guess what? The pressure is going to go even higher, and you might get more effect from your SLT, but you then still have to supplement it with an eye drop anyway. So in that particular situation, again, not knowing anything else about the case, I would probably keep the drop and just supplement with SLT.
How quickly would you consider treating the other 180 degrees of the angle after SLT of the inferior 180 being done?
As soon as I see the eye has no inflammation. So, I'm not going to see this patient for at least 6 weeks. So in my book, in my clinic, theoretically, the soonest I'm even going to consider doing it is 6 weeks. I do the procedure, the patient comes back in 6 weeks, the pressure is not better at all, or better minimally. Then I might do, if the eye is white and quiet and otherwise in good shape, I might do an SLT right there and then. So that's 6 weeks. That's the soonest I would consider. Practically speaking, it ends up being few months because, let's say the patient comes back and their pressure is not good. Well, we know there's fluctuation in IOP, right? Depending on the time of the day and everything. So before I call, that scenario a failure in SLT treatment, I'd like to see that patient one more time, measure the pressure one more time. And if I get steady IOPs that are not controlled, then I'm going to start thinking about a repeat SLT. So when you add all of this up, it ends up being 2 to 3 months later. But theoretically, you can do it as soon as 6 to 8 weeks. But again, it's just hard to trust. I don't want to make a medical decision based on one number. I'd rather this patient come back in another few weeks or another month, recheck the pressure, see where they're at. And if they're not controlled, by all means, we'll do another SLT. But at least I would have 2 pressure readings, and it would make me more comfortable that that's the true IOP.
Okay, what risks do you disclose in your consent IOP spikes that might not be transient? For example, more pigment with persistent spikes needing surgical intervention.
I would say that's really more of a theoretical risk than a practical risk. In our consent form, we say there's a risk of IOP spikes, but as ophthalmologists, we're well trained to manage IOP spikes. We have many different eye drops, and an IOP spike is exactly what it sounds like. It's a spike. It's not up there to stay there. In terms of what if the pressure goes up and stays there, then again, number one, I've never seen it. Number two, when you look at the literature, what are the chances of you getting that? I'm not aware of any case, myself, my colleagues, or in the literature, of someone who got SLT and they got a pressure spike to the point of needing a surgery. That, to my knowledge, has not happened. If someone has had that experience, then I'd love to hear about it. So it typically ends up being an IOP spike that I'm going to give them one drop for a few days, or at least putting a few drops in the clinic and make sure the pressure comes down before they leave the clinic. So theoretically, is that possible? Anything is possible, but practically, I'm not aware of it myself or in the literature.
That's good to hear. Do you have any preference as to a specific Latina gonio lens that's to be used?
We use single-use lenses. It just ends up being easier for everyone involved. I don't have to worry about cleaning the instruments, and especially with COVID, you worry about risk of transmission, especially if you have few patients back to back. So we use single-use gonio lenses for SLT, and they're very cheap. You just open the package, put the gonio gel on it, and you're done, and then you toss it to the trash. So that's my preference.
Do you know if there's any discomfort to the treatment?
So, I have a lot of patients that ask about, so what do you mean by discomfort? And I tell them anything an eye doctor would do to you is going to have some discomfort, including putting an eye drop, including putting a numbing eye drop. When I first putting a numbing eye drop, guess what? You're going to have some discomfort, burning, stinging before the effect weighs in. With SLT, no one to this date has told me they have pain either during the procedure or after the procedure. But what I tell them to expect is some light sensitivity, some ache and soreness, mainly because me holding the lens on the eye. And theoretically, if you're not holding the lens properly, you can scratch the cornea. That would definitely be painful. But as long as you have enough gonial lens, as long as the eye is numb, I don't expect any pain or discomfort. But we still obviously write it in our consent form because, discomfort means different things to different people. Some patients, sit at a slit lamp and the neck is not comforting to them, the neck position, and they call that discomfort. So then you have to ask, what is it that they mean by that?
Do you routinely have patients wash out topical meds prior to SLT?
Depends on how bothered I am by them being on the eye drop. If it's a patient that's on latanoprost, let's say, and I know the latanoprost has brought the pressure down, and I know that the patient does not have a lot of side effects of latanoprost, they're overall doing okay in terms of compliance and side effect profile with latanoprost, and I realize, well, I need my pressure to be lower, I'm going to keep the latanoprost. There's no reason why to wash it out. I'm just going to go for the SLT. If there's a patient that comes and says, and I look at the pressures and I see the pressures are excellent, except the patient complains. These drops burn. I forget them. I travel a lot. I forget to take it. Well, that's exactly the type of patient. I'm going to take them off the drop. I'm going to do a quick washout period, and then I'm going to schedule them for an SLT. But just because you're going to do an SLT doesn't mean you have to discontinue the eye drop. It depends on how they're doing with the eye drop, what's their pressure as it is with the eye drop, and what's your pressure goal.
What happens if the ciliary body or another structure is hit with the laser? Is it just that there is no effect on IOP?
Number one, no effect on IOP. Number two, that's the one that the patient might feel. Ciliary body has a lot of nerves in it. Even during surgery, for anyone that does cataract surgery, if any of your instruments touches the ciliary body, that's when the patient jumps. So your patient might feel it. They might still not feel it depending on the energy setting you have, but that's when people say, yeah, I could tell. They still wouldn't say pain, but they would say, I could tell something was being done every time you hit the laser. I could feel something in my eye. And then obviously, that's number one. Number two, you shouldn't expect any IOP effect, obviously.
Thank you so much. So now we're about 4 minutes left of the presentation. A couple of these questions, I believe you've already set some answers. I'm going to ask a couple of them one more time and for the next couple minutes, and then we will end the presentation there. So here's the last couple questions. Do you use SLT to try to get patients who are desiring to get off of some of their drops to decrease the treatment burden? And how successful has that been?
The answer is yes, and very successful. So I feel like since I came to this practice, I essentially inherited the patients of another doctor in the community. And my number one job for a lot of these mild to moderate glaucoma patients on eye drops is at least telling them about the options they have. Mrs. Jones, your pressure is controlled on latanoprost. Just so you know, if there's anything that bothers you with latanoprost, it's cost, it's annoyance of putting an eye drop in your eye every night, compliance, know that you have other options. And I would talk about laser. And in my experience, as soon as you use the word laser, people get scared. But once you explain, this is a few minutes in-office procedure, it's safe, it's effective, then I try to get them off drops, because it's hard to see a glaucoma patient on an eye drop that you ask, Mrs. Jones, how are you doing? And them saying, great, I love everything with my eyes. It's almost always, these eye drops burn, my eyes red, it's dryness, stinging. So to avoid that, or at least offer them a solution for it, I offer everyone who's on an eye drop, who's a candidate for SLT, that there's an option that we might be able to get off the drops. I never promise it.
If a patient is on a PGA, would you stop at 4 weeks before trying to switch to an SLT?
If I'm happy with the pressure they're at with the PGA, then yes, I'm going to stop it, ask them to come back in 6 weeks or so and do the procedure. If I'm not happy with the pressure despite the eye drop, then I'm going to keep them on it and then do the SLT.
Okay, so if you do have a drug washout, how long will it be? And I think you just kind of said it, but could you repeat what you said?
I would do 6 weeks. Again, a lot of these studies, from the pharmaceutical company, they really want to make sure the medicine is cleared from your body beyond a shadow of doubt. So they usually go for an overkill, like many weeks or months. In my experience, 4 to 6 weeks, that should be more than adequate.
Okay, perfect. And I'm going to end with one more question. It is something that you've already said, but just as a wrap up, last statement, when you are repeating the SLT treatment the second time, do you treat the same area, and how long do you wait to repeat SLT?
So I treat this, I almost always treat the inferior angle first. And then if I need to supplement it with a second episode of SLT, I'm going to go after the superior part. Despite evidence showing I could have gone for the inferior part and probably get the same response, to me, it just makes more sense go after the untouched area of the angle. So I go after the superior for that second episode. How long do I wait? Again, as we talked about it already, I'm going to wait 6 weeks from that first SLT to even see a response. Let's say I'm not happy with the response. Am I going to jump to another SLT? No, I'm going to ask the patient to come back in another month or another 6 weeks just to get another pressure reading. I'm not going to make a medical decision based on one pressure reading. I'd like to see 2 or 3 before we say, okay, the SLT didn't work as much as we wanted to. Let's bump up the treatment.
Okay, thank you so much, Dr. Marvasti, for your time. And of course, with the audience, thank you so much for all of your questions and making this a very interactive and interesting Q&A session. And the answers were extremely helpful. So thank you so much for your time. And on behalf of Advancing Eye Care and LIGHTMED, we thank you everybody for attending. And of course, thank you so much, Dr. Marvasti, for an excellent presentation.